afternoon, ladies and gentlemen. First, I'd like to thank to the organizing committee to allow me to show our 10 years experience in pediatric epilepsy surgery. And I'm very sorry that we can't meet in person during the meeting. I think the goal of pediatric epilepsy surgery is different from adult. We are not only to achieve seizure freedom, but also we really want to improve the functional outcome of the children, because they usually have neuronal plasticity, especially for children younger than 6 years old. I think now epilepsy encephalopathy is confirmed, so we have to stop the seizure as soon as possible for these drug-resistant epilepsy children. In the past 10 years, our pediatric epilepsy surgery team performed about 300 cases. And even during the last year, pandemic of COVID-19, we still have 35 cases a year. And from 2010 to 19, I personally operated for 271 epilepsy surgeries in Taipei Veterans General Hospital, which included staged or repeated surgery and some phase 2 studies, but not included stereo EEG. Stereo EEG was performed by Dr. Lee, my colleague. And in this case series, the most common pathology is FCD, and usually the outcome is good for type 2B. Now, almost 85% have good epilepsy outcome. And tumor epilepsy surgery has the best outcome. 93% of our series that become seizure-free. Tuberous sclerosis complex is surgical indicated in many cases because they are usually drug-resistant. But many times you have to remove more than 2 tubers, and the seizure outcome is not as good as tumor. In our series, only 70% has good epilepsy outcome. Disconnection surgery is more and more important in pediatric epilepsy surgery. In the past 10 years, we performed 9 hemispherotomy, 5 quadrantic disconnection, and include anterior and posterior, and totally 68 classotomy. And in recent years, more and more cases are MRI negative, and we need stereo EEG. And for epilepsy surgery, I think learning curve and the teamwork is very important. So our seizure outcome was improved from 25% of good epilepsy outcome during 2011, and improved to now is almost 82% good epilepsy outcome in 2019. For epilepsy surgery survey is very important, and you need to use every modality you have, because the epilepsy network is usually very complicated. But I think the most important is teamwork. And in the end, from now, we think the basic semiology is one of the most important. So semiology and MRI is the two most important way we usually discuss a lot during the combined meeting of epilepsy surgery. And because of more and more MR negative cases, we are now need more phase 2 studies. But in recent 5 years, we almost abandoned subdural grid and the WADA test. We are now doing more and more stereo EEG and the cortical mapping. And tumor epilepsy surgery, like I say, has the best outcome in our series. The most common location is over temporal lobe. Second is frontal lobe. The most common pathology is ganglioma followed by DNET. and seizure outcome is very good, 93% of good outcome, and even the seizure recurred, you can do repeated epilepsy surgery, and all had good outcome. So like this case, you can see there's a gangrene glioma in the motor cortex. You can still remove totally and safely. And the patient has very good motor function after surgery. And for this DNET in the motor cortex also, you can remove the cortical part of the DNET, preserve the 5-meter part, and the patient can still have very good functional outcome like this, and seizure free. And many tumors located in insula region, which is very difficult, especially you want to preserve the motor function. So usually we need to do the surgery under IOM, but still you can achieve good outcome like these 3 cases, pre-op and post-op. And there is one case I have to mention, that because the tumor is in the insula region, and the parents of the boy was very hesitant to do the surgery, so they were followed up for 3 years. Also, he is already drug resistant. But suddenly, last year, you can see the tumor grow up very quickly, and the patient come to our ER with coma status. So we do the operation immediately, and the patient become glioblastoma. So I think tumor region need aggressive surgery, because in our series, we have 5 cases of high-grade glioma. Also, usually in this group, the prognosis of survival is better, but still, if you delay the treatment, I think it will make a worse outcome. And also very important is hypothalamic hamartoma, which the seizure occur very early and usually become drug resistant. So surgery is indicated. So we perform every approach for this epilepsy. We use gamma knife, we use endoscope, we use craniotomy. But now I prefer craniotomy and endoscope approach. It has a better seizure outcome. So this is how we do in endoscope. And so the take-home message for this tumor lesion and cavernous malformation hypothalamic, I think epilepsy surgery is indicated if it's become drug resistant even in 1 year. We suggest perform its surgery aggressively. And it's surgical resectable even in the Arakan area. Don't hesitate about surgery. If you have IOM, it's safe. And the epilepsy outcome is usually good. More than 90% will be seizure free in 2 years. And repeated surgery for recurrence is also indicated and very safe. And the long-term survival of this group is good, and the surgery will improve quality of life. And for this lesion, MRI is the most important. You just follow the lesion. EEG or the epileptic discharge activity is may be multifocal. And also for hemispherotomy is a very important epilepsy surgery in children. And in the past, it is one of the biggest surgery for pediatric neurosurgeon. The wound is very big, the surgical time is long. But now we like the disconnected hemispherotomy. We try lateral approach, we try functional, we also try vertical. But now I prefer vertical perithalamic hemispherotomy like this, because it has small incision, small craniotomy, and the surgical time is usually less than 7 hours, many times only 4 to 5 hours, and the blood loss is much less, and there is no age limiting and no shunt, no EV after surgery. And this is our first case after surgery. It's like this. He can sit up very quickly from bedridden 1 month post-op, and in 2 years and 3 years follow-up, she improved a lot with seizure freedom. And this is post-operative MRI. You can see it's really a minimal invasive disconnection surgery. So currently, I perform 6 cases of vertical perithalamic hemispherotomy, and the surgical time is less, and all achieve ENGOT Class 1 outcome for more than 1 year follow-up. There is no EVD, no permanent shunt after surgery, and ICU stay is much less. And also, total corpus callosum is very important for disconnection and epilepsy surgery for difficult case like Lennox-Gastaut. And when we perform total callosotomy, the seizure outcome was much better than anterior 2/3 callosotomy. And also, we use the functional connectivity study. We find out that early recovery and the recurrence of the epilepsy is because of the anterior commissure. So now we not only do total callosotomy, we also perform hippocampal and the anterior commissurotomy, and we can now do it with navigation under endoscopy. So the take-home message number 2 is for disconnection surgery. Like vertical perithalamic hemisphere is a very good approach for the hemispheric drug-resistant epilepsy in children. The seizure outcome is improved to more than 90% seizure-free, because you can do the complete disconnection due to you recognize the landmarks. So the outcome is better than anatomical hemispherotomy. And there is no definite age limitation, and the blood loss, operation time, and the shunting rate is very much better. So if you choose good case, it's very good, and also it's need learning curve. But now you can also perform anterior or posterior quadratic disconnection epilepsy surgery for appropriate patient. And this tuberous sclerosis with SEGA is also very indicated for epilepsy surgery. So this 9-year boy already under everolimus still has drug-resistant epilepsy, and he also suffered from oral ulcer very much. So his parents come to our clinic to ask a surgery. So we use sterile EEG and the semiology to confirm the which tuber is epileptogenic like this. So after we remove the left orbital frontal 2 tubers, the patient becomes seizure-free, and the postoperative EEG is like this, and his condition is much improved. So this is the postoperative MRI. We removed not only 2 tubers, we also removed the SEGA and preserved the phonics, so the patient didn't suffer from the dementia. So the take-home message number 3 for summary is that epilepsy surgery, even you can do it in staged or repeated approach, and it now is very safe and effective, especially for FCD type 2B and tuberous sclerosis. And for the patient, if their seizure duration is less than 2 years and age under 2 years, if you do the surgery earlier, they have better outcome. And the epilepsy and the cognitive outcome are usually mutually interactive. So if you have good epilepsy outcome, you have good cognitive outcome. And minimally invasive is now the trend, the principle. Now you can also use radio frequency ablation, laser lit, or HIFU ultrasound. And I think in the future it will become more and more important. And the number of the lesions now is not a problem. For tuberous sclerosis, you can remove 3 or even more tubers to achieve seizure-free. And neuromodulation like VNS, like DBS and RNS is in progress. They will become more and more effective in the future. But I think most important is multidisciplinary teamwork. Teamwork is very, very important. Work together, you can make the patient better outcome. So thank you for your attention.